Good morning. Good morning, all. This is exactly what we wanted. Lots of talking, lots of connecting. So I'm sorry that we're running a couple minutes behind, but this is exactly what the purpose of this event is. Thank you all for being here at the 2024 Political Drivers of Health Symposium. We're so grateful that you could take the time in between this busy holiday end of year time to be here. I want to just take a second to look around the room and recognize that we have clinicians here, state agency leaders, healthcare, health system leaders, clinicians, faith leaders, hospital trustees, and so many more, patient advocates. So thank you all for being here, and thank you all for being healthcare advocates in your own right. This morning, we're going to have the opportunity to learn, connect, and engage a little bit with our policymakers. I did see Senator Gray somewhere here, so thanks for being here, Senator. First, Dr. Philip Alberti is going to, and Dr. Joanne Conroy are going to frame our day by defining and outlining what exactly political drivers of health are, what's health justice, and how do we work to have better healthcare access in our state. Then we're going to take some time to break out into breakout sessions, and you've all signed up for a breakout session that you may be interested in. We have 5 breakout sessions. We're going to be exploring timely access to clinically appropriate care in our Right Care, Right Time breakout session. We, in New Hampshire today, we have more than 100 people that are stuck in hospitals because we don't have adequate long-term care infrastructure to allow discharge back to our community settings. So we have the New Hampshire Healthcare Association, the New Hampshire Office of Public Guardian, the Roman Catholic Diocese, and Dartmouth Health to discuss areas of opportunity where we can provide necessary supports for patients who are clinically ready to discharge but are unable to do so. We're going to be spending some time in the maternal health care breakout session discussing how do we better support women who are navigating the postpartum period. It's a pretty challenging period. The Department of Health and Human Services Chief Medical Officer, Dr. Jonathan Ballard, the Women's Foundation, the Northern New England Perinatal Quality Improvement Network, and a maternal health care advocate are going to be talking about areas of opportunity for our maternal health care supports and services. We know our youth are struggling right now. We're living in a world with cell phones and constant pressures. And we want to find ways to better support our youth so they can maintain good mental health. So NAMI New Hampshire, an education administrator, a student, and a Dartmouth Health representative will discuss areas of policy opportunity to support and protect our youth. We will have a childcare breakout session and a housing breakout session. Childcare and housing keep coming up as constant pressures for our workforce. In the childcare breakout session, we're going to be talking about how do families find quality childcare, and then how do they afford it? So we have New Futures, Granite United Way, New Hampshire Fiscal Policy Institute, and Dartmouth Health representative examining our childcare infrastructure and how do we make policy investments in that. And finally, our housing infrastructure. Over the last several years, particularly over the last couple years, we've made significant infrastructure investments in New Hampshire in our housing stock. But the New Hampshire Business and Economic Affairs, the New Hampshire Business Industry Association, New Hampshire Housing Finance Authority, and Dartmouth Health will be noting recent investments and discussing further areas of opportunity. We're going to spend some time at lunch as an open lunch. No programming, but we want you to spend some time to connect. I have a challenge for all of you during our lunch hour. I would love for everybody to meet 2 new people. Sometimes we sit at tables with people who we know, but the challenge is try to meet 2 new people today. And finally, we'll close the day with a bipartisan, bicameral legislative panel. We're so thrilled to have Representative Erica Leon, who's a Republican from Derry. She serves as the Vice Chair in Health and Human Services. Representative Alexis Sampson, who's a Democrat from Exeter, who's the newly chosen Democratic leader in the House. Senator Cindy Rosenwald, who's a Democrat from Nashua, and she's a longstanding senator who is serving on finance, will be an important position in this year's budget cycle. And finally, newly elected Senator Rochford, who is a Practicing pharmacist, has served on the Board of Pharmacy, was in the House of Representatives, now is a senator, and will be the rising chair for Senate Health and Human Services. Today, we have an opportunity to branch out, to connect, and I'm so grateful to have you all here. This is where we're going to be able to really shape our roadmap for the 2025 legislative session. So without further ado, it's my privilege to introduce our featured speaker, Dr. Philip Alberti. Hold on one second, Philip, let me introduce you. He is the AAMC's, or the Association of American Medical Colleges, Senior Director of Health Equity Research and Policy. He, like many of us, he has a couple of titles. He's also the founding director of the Center for Health Justice at the AAMC. He has 2 decades of professional experience, having nurtured a longstanding passion for research, implementing and evaluating systems and policies that help every community have an equitable chance to thrive. As the founding director of the Center for Health Justice, Philip is developing efforts to build true community collaborations and an aligned agenda for better health throughout the country. This work is fueled by a strong belief that solutions to health injustice exist within our communities themselves, and that the path to better health goes before medical care to working alongside partners across multiple sectors that impact everyday lives. Philip, thanks for coming and being with us here in New Hampshire, all the way from DC, and we're thrilled to have you.
Good morning, everybody. I'm so excited to be here. Thank you for the introduction, Courtney. It's really an honor and a privilege to be here helping you all think about and strategize how to improve the health of all residents of the state of New Hampshire. So we're just going to dive into it. So we're going to talk about, didn't realize, health equity, health justice, and political determinants of health. So for those of you that don't know, the Association of American Medical Colleges, where I serve as the Senior Director for Health Equity Research and Policy, is a nationally representative membership association representing 159 LCME accredited medical schools, about 400 teaching hospitals, and 70 or 80 academic societies. And the mission of our organization is to lead and serve that diverse group of members to improve the health of all people everywhere. And our Center for Health Justice was born out of our strategic plan, which began in 2019. And it really exists as a place for communities and all sectors to come together to ensure that all communities thrive. And if there's one message that you take away from these 20 minutes in my conversation with Dr. Conroy, is that health equity, this goal of health equity, benefits all communities. I think my community, the health equity community, has done a terrible job of making the case that our goal of all communities thriving truly does include all communities. This is not some Robin Hood health justice where we're stealing health from community A to give it to community B. We can make choices where all communities truly thrive. And so the way that I think we get there, and we'll go through some of these stages, is we start with trustworthiness. What does it mean for our organizations, our institutions, to demonstrate they are truly worthy of community trust? Right? And then how do we work with that trustworthiness to meaningfully co-create the solutions that Courtney mentioned with our local communities, as diverse as those communities are? And we do that work in service of a process of health justice, which I'll define in a little bit, to get to that goal of health equity where all communities thrive. And so at the Center for Health Justice, this is our mantra, right? Health equity is our goal, health justice is the path. And so I'm going to start with the end in mind and define health equity, and then we can work backwards all the way down to trustworthiness. So we start with this lodestar definition of health equity. Right? This is the CDC's definition. Health equity is a state in which every community has a fair and just opportunity to attain their highest level of health. Now, the bold-faced text is my own, right? Fair and just opportunity. And I really want to emphasize this. Opportunity for health is the outcome. And I don't mean some kind of fake opportunity where a mayor says, well, you said you wanted an opportunity to have fresh vegetables, and so I built you that supermarket, and it's 4 miles down the road. There's no sidewalks, and there's no public transportation, but you had the opportunity to access. That's not what I mean. I mean real, true, easy opportunity for health by default. And why am I stressing this word opportunity so much for us today? And it's because those whose values and whose goals run perpendicular to that goal of fair and just opportunity use that word against us. Right? So here's an editorial from 2021 where Dr. Ben Carson said, rather than equality of opportunity, what I just said is actually our goal, right? Equal opportunity. Rather than that, our movement, the health equity movement, demands equal outcomes. Nothing is further from the truth, right? So we are not un-American. We are not shunting aside equal opportunity to demand that all communities look and feel the same and have the same health. That's not the goal of health equity. It's that all communities have that fair and just opportunity to thrive, because I believe science shows, history shows, that when you have true equal opportunity, more equitable outcomes follow. Whether they're more equitable health outcomes, economic outcomes, educational outcomes, all the outcomes, right? But the goal is that equal opportunity. So I love that CDC definition, right? It's a little bit vague though, right? What does it mean for a community to provide that fair and just opportunity? So we at the center were early adopters of this framework. Just show of hands, who here is familiar with the Vital Conditions for Health and Well-Being framework? Excellent. Oh, that's more hands than I typically see raised, so good for you, New Hampshire. So a couple of reasons why I love this framework. So first, I don't love the fatalism of social determinants of health, right? As if your community conditions determine your health forever and it's non-negotiable. Right. Second, I love that the federal government, 47 agencies and departments across the federal government, inclusive but well beyond HHS, have adopted the Vital Conditions for Health framework for their own interagency coordination when it comes to community well-being, community resilience, and specifically community recovery after COVID. Right? So there's a language here at the federal level where if we are interested, and I'm sure we're all interested in tapping federal funds for this work, this is the language that our agencies and departments are now speaking. I also personally love, I already mentioned that I love to keep the goal in mind. I love how goal-oriented the Vital Conditions for Health framework is, right? So rather than saying, oh, we're going to address housing as a social determinant, and that word address could be anything. It could be referrals, it could be building new housing, it could be legislation. This instead says, I want every community to have humane housing. I don't care how you get there. It's going to look different in Concord than in Nashua than in Exeter. It's going to look different in Louisiana than in Alabama. Right? But the goal is that all communities have humane housing and reliable transportation and meaningful work and wealth and a thriving natural world. I also love, there's a whole bunch of reasons why I love this framework, that it's inherently multi-sector, and it makes it clear that the movement for health equity requires multitudes. It requires all of us, every sector, in a coordinated effort to achieve all communities thriving, bound together by flexing our collective civic muscle and feeling that we all have a place, that we all belong in that conversation. And for healthcare in particular, and I would say that many of you would agree, that it feels like healthcare, for better or for worse, is being asked to do a lot of this heavy lifting on its own. I think it's a great reminder of what healthcare actually owns in this space, right? You own acute care, obviously, and you own a large chunk of addiction treatment. But when it comes to those vital conditions for health, you own a sliver of a sliver. Because while that blue basic needs for health and safety, while that does include equitable access to high quality, affordable health care, it also includes other basic needs like drinkable water and breathable air and nutritious food, right? So there is nothing, no matter how many referrals you make to community-based organizations, that is not how we are going to achieve health equity. This is a multi-sector collective effort driven by the movement coming together to advocate and agitate for all communities thriving, these basic fundamental conditions. And the last reason that I love this is because I think that no matter what community you represent, no matter what community you're a part of, everybody wants these things, at the very least, for their own community. And I'm going to look no further than Missouri in the last election. So Missouri sent to the White House and the Senate, whoever they sent to the White House and the Senate, but they also, via their ballot initiatives, they gave themselves a minimum wage increase, they gave themselves guaranteed paid sick leave, and they overturned their abortion ban. Those are three health justice policies that maybe there's a cognitive dissonance between their federal representatives, but they voted all of their initiatives a straight health justice ticket, whether they recognize it or not. So we have to be smarter, right? We all want these things for ourselves, and folks vote this way when allowed to vote this way. So then for the center, we say that health equity then will be achieved when every community has and provides these basic fundamental building blocks for health and well-being. That's how we operationalize it. And again, it's wide open for how communities want to strategize to get there. So what stands in the way? Now we're getting into my own training and my own biases, so get ready. It might be a little uncomfortable for folks. What stands in the way of all communities thriving from my perspective, right? And so I came up in the school of thought, you can see my mentor's kind of seminal paper up there, that social conditions are fundamental causes of disease. So what social conditions am I talking about? I'm talking about all the isms: classism, racism, ableism, sexism, and they're represented here by this hydra. So what do these isms do? These isms, these fundamental causes, do a couple of things. One, they control access to which communities have these fundamental resources, these flexible resources for health. Which communities have voice and power and prestige and information. Which communities have them and which communities don't, right? They also, these fundamental causes, one cause can impact a whole array of outcomes, right? So think about all the literature out there now about segregation or redlining, right? And decades out, there are educational outcomes, there's health outcomes, there's wealth accrual outcomes. So one fundamental cause, a whole array of population health outcomes impacted by them. And the third characteristic of a fundamental cause is that they're clever. That, just like a hydra, when you chop off one head, another head grows. So I think Michelle Alexander, if folks haven't read this book, The New Jim Crow, lays out a fundamental cause argument around racism, right? So first we have slavery. Slavery becomes outlawed. You chop off that hydra head, boom, Jim Crow pops up. You outlaw Jim Crow, you chop off that hydra head, boom, mass incarceration pops up. They are clever. They don't need, that's why that multi-sector effort is so important, to address as many pathways through which fundamental causes operate as possible. But let's be very specific, because we don't have to look very far, unfortunately. In 2014, no, 2024, maybe that was wishful thinking, 2024, right, to see how these isms are embedded in our political drivers of health, what my friend Daniel Dawes calls the political determinants of health. So again, full on, these are my biases, but when I look at these policies, right, when I look at reproductive health restrictions, I see sexism. When I see or hear that there's a bill in certain states that is referred to as "don't say gay" as a gay man, I see heterosexism. When I think about work requirements, I think about I came up in New York City public health, and there was a law in New York City local governance where if you made above a certain amount of money, you didn't have to clock in, and if you made $1 less, you did have to clock in, right? Classism in the ways that our policies are operationalized. Who's more trustworthy, wealthier folks, less wealthy folks? And so let's really put a fine point on how these isms, through these political determinants of health, unjustly distribute across our communities, whether we're talking geographic communities or socio-demographic communities, those vital conditions for health. Let's be very clear, because healthcare restrictions, whether restrictions on gender-affirming care or reproductive health, directly remove basic needs for health and safety from select specific communities, right? Racist voting restrictions directly remove the ability of certain communities to flex their civic muscle, right? My mom has a place in Florida. I don't go to Florida, right? Because I don't feel that I belong. So don't say gay laws. My family and I feel that is heterosexism baked into policies, removing my sense of belonging, right? So these fundamental causes get embedded in our policies and our practices to unjustly distribute the very things, these fundamental building blocks that all of our communities need and want for themselves, thereby creating the health inequities, the economic inequities, the educational inequities that we have been grappling with for decades and centuries. So how do we fix this? What is the process? How do we undo these knots of isms? And so we in the center propose this framework of health justice, which we've operationalized as keeping one foot grounded in community wisdom and multi-sector partnership. As Courtney said, the solutions to these injustices do not sit in Capitol Hill or in your State House. They are in communities that have been navigating and grappling with these injustices, again, for decades and centuries. That's one foot. And then we use that foot to co-develop with our multi-sector partners and with our community experts the kind of evidence that can be baked into policy and practice change at all levels, organizational, local, state, and federal. And we in the center also then use both of those feet to walk towards that goal of all communities thriving in a very explicitly anti-racist and anti-discriminatory way, which for us comes back to power. Right? Who has the power at our small decision-making tables to decide which research questions gets asked, or which policies are interrogated, or whose expertise is actually incorporated into the solutions and tactics that we're developing. So it's all about power. And I'm going to say a little bit about each of these feet in turn very briefly, and then we'll turn it over to our conversation. So I want to talk about community engagement, because I think community engagement is maybe the least understood phrase, one of the very least understood phrases. Here's what I don't mean by community engagement. That you have a community advisory board that you convene 3 times a year, and 3 times a year, you bring your and your team's brilliant ideas. And you say, oh, community, don't you think my ideas are brilliant? Do you have any other ideas that maybe I'll incorporate into my, can I just get a thumbs up to my brilliant ideas? Check the box, community engaged. That is not what we're talking about when it comes to authentic, meaningful community engagement that co-creates the evidence and the power needed to shift our communities towards health opportunity. So this framework from the National Academies of Medicine lays out not only how to evaluate whether your community engagement is authentic, and those are kind of those 4 petals, those domains of evaluation, but it very explicitly notes the adjectives, the descriptors of what authentic community engagement is. It is co-developed. It is shared governance. It is shared power. It's inclusive. And you can read the other 10 words. And then most importantly for me and my perspective is this word, trust, right? That you cannot even begin to break bread and build bridges if there is no trust between your organization, your institution, your politician, your healthcare leader, and the communities and communities of patients that you serve. Right? And so that's one of the reasons the very first thing that our center did in 2021 was release our Principles of Trustworthiness Toolkit, which we co-developed with community members from 7 different places across the US, and maybe Joanne and I will talk a little bit more about this. But this is a way that you can think about together, across communities, with your partners, across sectors, what are the hyper-local actions that organizations can take. This is about organizational competencies, right? What are the actions that an organization can take to demonstrate the key behaviors that these 7 communities identified as key to trustworthiness? Behaviors like respect, authenticity, transparency, humility, right? And the actions that a healthcare organization might take to express or demonstrate humility might be very different than the actions that your local police department takes, or your local public health department. And that's exactly the beauty of this framework, is that you co-create together specific actions and then hold each other accountable for demonstrating that you're worthy of community trust. And so one of the ways that we walk the talk on this community engagement and multi-sector partnership is that we've convened, since our center's very beginning, our own paid group of multi-sector experts, so 10 local and national experts who represent all of those vital conditions for health. And they ensure that the work of the center, in the spirit of all communities thriving, in the spirit of addressing vital conditions for health, that our work doesn't just resonate with healthcare or public health, but resonates with the arts, that resonates with education, that resonates with transportation and food justice. And so just a shameless plug, I think the application ends on Friday, but we are looking for 10 new members of our multi-sector partner group if you're interested. It's a pretty light lift, the application itself, but they're due on Friday. We already have many, but please, would love to have some representation from organizations in New Hampshire. So that's the community engagement foot. The one quick thing that I'll say about the science, the research to policy action, right? We are talking about evaluation science. That is something that most organizations do not do well. We're talking about implementation science, right? How you actually take something that's proven from an evidence perspective and then do it in the real world, right? We're talking about health policy research. We're talking about health impact assessments, right? We've done a lot of science documenting inequities. We've done a lot of science understanding why inequities exist, fundamental causes. The time is really now to identify solutions, to co-develop those solutions and put those solutions in place so that successes can spread and scale. And we believe that this process of health justice, the collaboration to co-develop evidence for policy and practice change, is even more important, I would say, than the outcome itself, because we'll never get to all communities thriving unless we truly, authentically work this process. So as a segue to the conversation with Dr. Conroy, I just want to talk about language and narrative and framing, which I'm sure is top of mind for all of you going forward. So this narrative guide, this was released by the Center for Health Justice and the American Medical Association in 2022. It is simultaneously the most popular and most vilified thing I've ever been engaged with. So I leave that to you and you can look at it and understand why. What this is not, it is not never say these words, always say these words. That is not what that is. We have seen in real time how language evolves and how language acceptability evolves. Instead, this is really about self-reflection to ensure that your language, whether you're talking about your grant proposals, your casual conversation in an elevator with a colleague, your doctor's notes, right, that all of the language you use is precise, inclusive, respectful, and action-oriented. Right? And lately, in the last 1 or 2 years, I've been adding a fifth word to this, and that's strategic. Right? How do we make sure that our language and our framing of these common goals of health equity, really that benefits all communities, and this common pathway of health justice, that even folks in Missouri are voting for policies that promote health justice, how do we make sure the way that we talk about our movement is strategic? And so we in the center do a lot of public opinion polling, and I'm just going to highlight findings that I think are illustrative of the importance of framing from one of our 2 recent polls that focus on environmental justice and climate justice. And so in our environmental justice poll, we asked a nationally representative of US adults, so it's nationally representative, across demographic groups. Like we asked, which groups in our country do you believe are more likely to be exposed to environmental hazards? And you can see here, 60% said low-income groups, right? And 40-something% said racial and ethnic minorities, right? So that was across all US adults, acknowledged that those 2 groups were more likely to be exposed to environmental hazards. And that's the way we framed the question. We defined what an environmental hazard was, and then folks responded as they would. Then we defined environmental injustice and what environmental injustice was. And then we asked the exact same question. Which groups in the US do you think are more likely to bear the burden of environmental injustice? Double-digit decreases in the recognition that low-income folks and racial and ethnic minorities suffer from injustice. So there's a belief in disproportionate exposure to hazards, which is kind of like cozying up to the definition of injustice. But when you suddenly use the word in the definition of injustice, recognition and awareness, and therefore maybe political will to change things, decreases. So that's one important thing about language, is that we need to understand what flies in certain places and spaces. I am not one, I'll put my cards on the table, I think the language shell game is a losing game for us, because they'll just change the words. So we have to be clever. How do we actually frame, and again, through that community engagement, how do we understand what's tenable, what's palatable, and what's not? And the good news is, from our polling, is that cross-ideological consensus abounds. A health justice agenda is a consensus agenda. 3/4 of self-identified conservative members of Gen Z think healthcare is a human right and the US government has a responsibility to provide it. 3/4 of self-identified conservative members of our youngest generation, right? US adults across all ideological spectrum think that these actions, term limits, voter ID laws, Supreme Court codes of conduct, increasing voting places, they all agree those would strengthen democracy. Do I agree with voter ID laws? I don't. But if voter ID laws get us more polling places, let's play. Let's go for it. Let's find that consensus agenda, right? And even reparations, reparative justice policies. We did a huge poll with a sample of over 10,000. We had state-level estimates. And when we just poll tested reparative justice policies without mentioning racial justice or reparations. There was not a state in the union where any of the policies we tested were those policies tested below 60%, including New Hampshire. Across ideologies, majority support, until you start talking about reparations and racial justice. So there is a consensus agenda for this because health equity benefits all communities. And that's the message. And so I think our big challenge together is to figure out how do we advocates in this room for racial, economic, social justice, how do we bring all communities into our tent without hiding or watering down our principles, our goals, and our values? I don't have an answer to this question, so there's no like big reveal. I wish I did. I don't, but I think that's part of the work of all of us today is to figure this out via community engagement, via cross-sector partnership, right? Via co-creation. How do we do this? Given that our work, our goals are truly popular, even if folks say they're not. So here's a bunch of ways for us to stay in touch. Thank you for allowing me this opportunity to introduce the day, and I look forward to talking with Joanne.